Hello and welcome to Season 2, Episode 83, Take 7 of the Physician Assistant Exam Review Podcast. So I'm closing in on 200 episodes, and I still can screw up the intro over and over and over again. This is Take 7. So hopefully this one goes okay and I don't delete another one. My name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review, and I am so excited to have you on board. I've been so excited with the community members, how everything's been going at the site for the podcast, in the app. It's just been a ton of fun. Really, really excited about what's going on. I've been working hard on the final step 2.0 to get that out to you. I did the initial print and release back in June, and that went really well. I've gotten fantastic feedback on that. Unfortunately, taking me a little longer than I thought to complete the audio version. It just takes time. There's no other way around it. And it's not something I can do with the kids in the house, and summertime makes that hard. So I really like it to be quiet for that. If there's a little background noise on the podcast, I'm okay with it. But I really don't want that to happen for the audiobook. So that's taking me a little bit longer than I thought to complete. But once that's done, I will get I'll make that version out and available for everybody. I'm really excited about it. I've gotten fantastic feedback on it. It's been a ton of fun to work on. But there are certainly some typos and things, not a lot of content issues. I've been pleasantly surprised at the very low amount of content issues we've come across. But there are certainly typos and periods in wrong places and question marks where there should be periods and that sorts of things. So we're working that out. But hopefully that'll be available September or October at the very latest. What else is going on? So it's summertime. Things are looking up around here. As always in the summer, days are longer, although they're just now starting to get a little bit shorter. We finished hematology, and that's super exciting. We're moving into GI this week, so very, very excited about that. I had initially thought when I started season 2 of the podcast, basically just going back through the PANCE blueprint again, that I would be rehashing a lot of the same stuff. It wouldn't take me that long. I'd just recopy the notes and move forward, but that really hasn't been the case. And as we move forward in GI, I'm finding it to still be true. And not that the things were missing, but I'm just adding content to it. I'm getting a better idea of what's important, how to help you remember things as we go through this the second time. So I'm really, really having a good time with that. As we start GI, I want you to know that I'm going to go through it. I looked through the blueprint and I'm going to cover it. We're going to start by organ. So we're going to go esophagus to the stomach, to the small intestine, to the colorectal, to the biliary system, and then to the liver, and then the pancreas, and then we'll move into all the other stuff is what I have planned here, rather than following the blueprint exactly, because they just go in alphabetical order, and I think that makes a little bit less sense. Hopefully, GI is a little more straightforward than hematology. Hematology, obviously, with the coagulation cascades and all the different factors and the way things work together, there's a lot more understanding and thinking in that section, I guess I would say, as opposed to GI, which is a little bit more straightforward. Here's the disease, here's the presentation, here's the treatment kind of situation. So you'll see as we go how that works. And I just want to share with you, before we jump in and get started with GI, 2 very exciting things I've got going on. One is if you don't have it yet, the Physician Assistant Exam Review app is out. I've been talking about it a lot in the emails, but if you're not on the email list, you would not be aware of that. And inside of the app is where I've been delivering a ton of content in there. It's where I deliver all the digital content for the final step audio stuff. The Scholars newsletter audio version is all in there. And there's a lot of, and I started a video podcast that is also hosted in there called Brian's Brains, and you might really enjoy that. So anyway, I'd love to get you inside there and take a look around and see how you think about that. You can find the Physician Assistant Exam Review app at www.physicianassistantexamreview.com/app. It's really simple. You will be asked to download the app, but it's contained within the Learnistic app. It sort of hosts it, so you'll see that as you move through. You create a free account, set that all up, and you will immediately get access to all the free content within the app. And it's really been a ton of fun to work with. Really excited about that platform. Now, in addition to that, if you want to look into, or you want to get, once you are poking around in that app and you're pretty excited about it and you see how powerful it is and how the content is delivered directly to your phone, that you can listen to it on the go. If you'd like to get the podcast in there, you can do that. Just go to www.physicianassistantexamreview.com esophagus.com/podcast, and you'll see how to get access to the podcast within the app right there. So those are the two things I'm really excited about and wanted to share with you. And that will have every single episode of the show ever produced, including episode 1, which you can't get on the website anymore. I've long since taken that embarrassing thing down, but I do have it available in the app at www.physicianassistantexamreview.com/podcast. All right, so without further ado, let's get into our priming questions for GI. What is the mainstay of diagnosing esophageal problems? What is the mainstay of diagnosing esophageal problems? A bird's beak on barium swallow is indicative of what condition? A bird's beak on barium swallow is indicative of what condition? And then our last one, esophageal varices are often related to what other condition? Esophageal varices are often related to what other condition? So we're going to start off with the esophagus today. I mentioned just a minute ago that we're going to walk through by organ initially, and so today's going to be Esophagus Day. Very exciting, I know. So esophagitis is our first topic here, and that's just an inflammation of the esophagus. Pretty straightforward stuff. One of the cool things about being in surgery and not being in medicine is I actually get to see the esophagus. When we do particular spine surgery called an ACDF, I'm trying to think of, as I say this, I'm trying to think of what that stands for. And, come on. I think it's anterior cervical discectomy and fusion. So what we do is we go in to the cervical spine, we take out the degenerative disc, and then we put a spacer block in or a bone block or something to hold that space open, and then we put some screws across it and it fuses the joint space there. But when we do that, we go in through the front of the neck instead of through the back. And a big part of my job on that surgery is to hold the esophagus out of the way, because it will continue to try to slip past and get under the retractor and directly in the way of the drills and whatnot. So that's pretty much my job. But the cool part is, like I said, is I get to actually touch the esophagus, which makes all this stuff come to life a little bit more. And I think once you get out into the clinic, once you get out into practice, that's kind of what rotations are for, is to bring this stuff to life a little bit more. So I'm hoping in your surgery rotations, you get to see stuff like that, and it helps you to hold on to this information. So causes of esophagitis. GERD is one. We'll get to that in a second. Medications can cause esophagitis. So again, we're just talking about inflammation of the esophagus. Medications like NSAIDs, certain antibiotics. I'm not going to go through the list. Bisphosphonates is a good one. If you remember when you cover musculoskeletal, they talk about that those can be irritating to the esophagus. And then there are tons of others. I'm not going to go through them. It's a big, long list. Medications can bigger pills can sort of get stuck and cause a problem, but in general, medications can cause esophagitis. Excessive alcohol consumption is another one. And then infections. You can get an infection of the esophagus. These tend to be more in an immunocompromised patient, so keep that in mind for your question stems. You can get an infection with Candida, herpes, cytomegalovirus. And how will these patients present? Well, exactly like you think. Stop and think about it rather than memorizing this stuff. How would a patient with esophagitis present? They might have a little heartburn, a little nausea, a little cough. They may have difficulty swallowing or pain with swallowing. So what was it? Do you know the term for difficulty swallowing? It's dysphagia. Odonophagia is painful swallowing. I should have made that our priming questions. Labs and studies. You're going to get an endoscopy with a biopsy here in order to diagnose what's causing this. So if there's a herpes infection, these are described as multiple shallow ulcers throughout the esophagus. If you have a CMV infection, they're large, solitary, deep ulcers. They just look different. Different viruses affect the esophagus in different ways. When you put a scope down someone's throat and look at their esophagus, you can actually see these markings. Candida will be similar to where we find in other places. It'll be raised white plaques, which can be scraped off. Our treatment is going to be based on a diagnosis, right? I used to love when patients would come in and you'd say, well, I'm not sure exactly what's wrong. We're going to get a couple tests and then we'll find out. And they'd say, well, how are you going to treat this? What are we going to do? I say, well, we don't have a diagnosis, so I can't treat it yet. Now, obviously, that's a little off the cuff. There are broad spectrum things you can do for certain situations, but here we're going to be treating the diagnosis. So if it's something like a medication, we're going to stop the medication. If it's alcohol, we're going to attempt to stop the alcohol. So stop the offending agent. If it's GERD, again, we'll get to that in just a second, but antacids and PPIs may be effective. If it's Candida, fluconazole 3 times a week. Cytomegalovirus, here we'd use antivirals, and same with herpes. Zenker's diverticulum is next. And this is just diverticula within the esophagus. Diverticula are little pouches or outpouches of weakened walls. So you get diverticulum in the colon, but you can also get it in the esophagus. Clinical presentation, again, stop and think. What would these patients feel like if they had little pouches in their esophagus that could capture food on the way by? What would happen? Well, they could present this by regurgitating undigested foods hours after the meal, right? Because that food never moves all the way down. They'd have bad breath, right? If you have little pouches with food stuck in it in your esophagus, you'd have bad breath, some neck pain, and again, odonophagia and dysphagia. Labs and studies, again, we have a barium swallow, which is going to be some radio-opaque dye that the patient swallows, and then we take x-rays as it moves through, and you can get an idea of what the esophagus looks like. You can also do an endoscopy, which is both diagnostic and therapeutic, which is kind of cool. It's diagnostic because you can look around, right, and see what's going on in the esophagus. But the other thing is they make endoscopic tools like a stapler to staple off those pouches if they can find them and they see that they're a good enough size. There are also things like endoscopic lasers and other ways you can do it. But from what I came across, stapling seems like the mainstay now, although like I said, that's not something in my wheelhouse. It's not something I do. So that's just an example. Treatments. Behavioral modifications can help. So hydration after meals and thorough chewing. And like we just said, endoscopic repair or surgical repair. But obviously endoscopically, it's a little less invasive. But the idea is you want to obliterate those pouches and reinforce them. Next, we have achalasia. This is decreased peristalsis of the esophagus, along with increased muscle tone of the lower esophagus. So peristalsis is that rhythmic contraction that pushes the food along. Our clinical presentation here, again, just think this through. Regurgitation of undigested foods. And then we have progressive dysphagia with both fluids and solids. These patients will also have some non-cardiac chest pain. Labs and studies. Here we're going to do a barium swallow as well. This will show a clear tapering at the lower esophageal sphincter. It looks kind of like a bird's beak or a rat's tail, as it can be described as. But those are your key terms there that I think are going to be really valuable for you to hold on to. And if you can take a look at the picture of that, like go to Wikipedia or something and pull up a picture of what that looks like, it'll really stand out in your mind. You can also do an endoscopy here. Treatment, calcium channel blockers like nifedipine, nitrates, Botox injections, pneumatic dilation, and then you can go in and actually surgically correct this. Mallory-Weiss tears are longitudinal mucosal lacerations of the esophagus. These are often associated with forced retching and vomiting, typically associated with alcohol. So you have someone who has drank way too much or maybe has done that on multiple occasions, and that forced retching causes tears in the esophageal lining, in the mucosa. So again, what do you think we're going to have here? We're going to have hemoptysis. We're vomiting blood. That's our main symptom. We can get epigastric pain and back pain. Labs and studies, you can do an endoscopy to find those lacerations. But the bleeding is typically self-limited. You could use that endoscopy again. That can be therapeutic and diagnostic. So we can inject epinephrine or coagulate the bleeding. And when I say that, I realize as that my pause there was because you don't have a clear understanding of what I mean there. When I say coagulate the bleeding, what I'm talking about is with electrocautery or thermal cautery. which is a surgical tool where you just sort of burn the blood vessels and they stop bleeding. Obviously, in bad cases, a transfusion may be necessary if you can't get the bleeding under control. Esophageal stricture is next, which seems similar, but it has more to do, similar to achalasia, but achalasia has more to do with the peristalsis functioning, and esophageal strictures is more just a narrowing of the esophagus. Patients will often have a history of GERD. And again, our clinical presentation is going to be very similar, right, as to all the rest of these. Dysphagia, donophagia, heartburn, cough, and hiccups is included in this one. Labs and studies, surprise, surprise, we have a barium swallow and endoscopy. Treatment, proton pump inhibitors like omeprazole, H2 blockers, and surgical correction. Esophageal varices. These are dilated veins, usually of the lower portion of the esophagus. What happens is we get portal hypertension is the most common predisposing factor, which is typically secondary to cirrhosis, liver cirrhosis, which is often secondary to alcoholism. Alcohol is not good for your GI tract. Clinical presentation here. If we have esophageal varices, so we have these big dilated veins in the esophagus, we can get hemoptysis, so that bloody vomit. You can get basically what looks like a GI bleed, which I guess it is, as a black, tarry, bloody stool. But if you're bleeding in the esophagus, by the time it comes out in your stool, it is not bright red blood. You're not going to see bright red blood from an esophageal bleed. You're going to see black, tarry stool. Bright red blood is going to be directly from the rectum. And you may also get signs and symptoms of a GI bleed here, things like lightheaded. If you're losing a decent amount of blood, you can get symptoms of that. Labs and studies and endoscopy is going to help us take a look at what's going on down there, and a CBC. Treatment, fluids. Again, endoscopy, you can ligate or ban those variceals. There's sclerotherapy, so you can get rid of those vessels and balloon tamponade off the bleeding. Again, if patients are in trouble, you can do a transfusion. Our last major topic for today is the gastroesophageal reflux disease, or GERD, right? We're all pretty familiar with GERD. This is when the sphincter between the stomach and the esophagus relaxes, allowing acid from the stomach to move into the esophagus. The esophagus is not designed to handle large volumes of stomach acid. It does not do well. Clinical presentation, substernal chest pain. Chest pain is a good one. Pain which is typically postprandial and relieved with antacids. Dysphagia. A chronic dry cough is a good one here, and chronic laryngitis is another good one. Those are symptoms that should set off these little red flags in your head and point you towards GERD. Doesn't mean it is, right? None of these are conclusive, but they just sort of shift you in a direction. Endoscopy is really not necessary, and a barium swallow also isn't really going to help you here. But you're going to do both of those to rule out all of the other things we talked about so far, right? Because everything has very, very similar symptoms. So it's going to be hard to tease out from a patient's history which of these esophageal problems they have, right? As I went through them, you're probably thinking, geez, it's got the same list. It's got the same list. It's got the same list. All of every esophageal problem gives you a little bit, it might give you a little chest pain, might give you a little difficulty swallowing, might give you a little pain with swallowing. Yes, there are caveats after that with the bad breath. You want to hold on to that. Hemoptysis, you want to hold on to that. But overall, they're very similar. So it's going to be your endoscopy that's really going to help you, or your barium swallow that's going to help you determine which is which. Or in this case, if it is relieved with antacids, that might give you a clue too. So treatment for GERD, behavioral modification, so smaller portion sizes can help. Recommending that patients don't lay down after meals. Weight reduction has been shown to help. Avoiding acidic foods like spaghetti sauce or tomatoes, lemons, that sort of thing. And then avoiding things that relax the lower esophageal sphincter. So there are things that will relax that muscle. Fatty foods will do this. Mints will do this. Chocolate, alcohol, and smoking will all release that, will cause that sphincter to relax a little bit more. And if you're already having a problem with that, well, now we're doubling that problem. Medical treatment, over-the-counter antacids, H2 blockers like Zantac, Pepcid, or Tagamet, which is ranitidine, famotidine, and cimetidine. Proton pump inhibitors is another way to go. PPIs like omeprazole, which is Prilosec, and lansoprazole, which is Prevacid. There are also surgical corrections for this, but we don't need to go much deeper than understanding that they are available. Patients with GERD are at an increased risk for esophageal strictures, like we talked about before, which makes sense. If you've got this acid washing back up into the esophagus, it makes sense that you could cause some scarring and create some strictures. They're also at risk for Barrett's esophagus, which is a pre-malignant esophageal issue, which is believed to be caused by that chronic exposure to gastric acids. And that will take care of the esophagus. So that's our first dive into the GI tract. Let's get started with our study tip. So today's study tip is going to be control what you can control. There are only so many things on test day that you can control, right? A lot of it isn't up to you. That feeling of being out of control creates anxiety. And that's what I want you to avoid, because anxiety is a killer. It keeps you from thinking correctly. It keeps you from thinking quickly. So we're trying to avoid anxiety in almost all we do here. The more questions you can recognize on the test, that's why we study, so that we can get things right and feel better about it and decrease our anxiety. So when I say control what you can control, what I mean is, let's talk about the PANCE in particular. Don't let things you can control contribute to your anxiety. There will be things you can't control. So for example, make sure you have your ID packed the night before, so that when you get there, you're not freaking out and wondering if you have it or not. Another one I came across recently, and I don't think I said this one in the last couple of shows. I really hope I didn't. I might have, because it's a good one, is I used to recommend driving to your location, drive to the site for your PANCE. And you say, why would I do that? I have a GPS. I know exactly how to get there. And if it's in your hometown or the town you're going to school in or whatever, that's fine. But if it's somewhere a little bit further away, even though you have it on GPS, which is what I did the last time I took my PAN read, being unfamiliar with the way you're traveling puts a lot of stress and anxiety into your system. Looking at the monitors doesn't seem like a lot, but when you've got such a big day in front of you, it's silly to add that to the list. Now, I'm sure it's going to take you to the right place, although recently I have a number of people who have shown up at the wrong baseball field because it didn't take them to the right place. But I'm pretty confident it'll get you there. It's not that. That's not the point here. The point here is to feel comfortable as you go, to recognize some of the landmarks as you go. So I recommend strongly that you go and drive to the site before your test day. Now, one thing that was brought up to me by a student that I think is a fantastic idea, I always thought you would do this a couple of days before. Why not, when you register, go drive by it a month before, 2 weeks before? So that day or two before, when you're panicking and you don't think you have time, you don't miss that opportunity. You can drive by the site a week before or 2 weeks before, and it'll have a very similar effect. A very calming effect on the day when you drive there and you recognize some of the landmarks and you get there comfortably. At least that's what I think. Anyway, let's wrap up with our priming questions for today. By now, you know the mainstay of diagnosing esophageal problems without question is a barium swallow and endoscopy. Pretty straightforward stuff. And what I mean here is I want you to pull out, and just like I talked about with symptoms, you don't have to memorize all of this, right? These aren't just lists of words to memorize. If someone's asking about a problem that you think is in the esophagus, how would you diagnose it? Well, you'd probably do a barium swallow or an endoscopy. If someone's complaining of symptoms that are related to the esophagus, they're probably going to be complaining of chest pain, dysphagia, odonophagia, those sorts of things. This isn't rocket science. It's pretty straightforward stuff. A bird's beak on barium swallow is indicative of what condition? A bird's beak on barium swallow is indicative of what condition? Achalasia. Now be careful. You're not going to see the word bird's beak on your test, right? I have people email me and say they don't do key terms anymore on the test. Brian, I don't know if I should study these. They aren't. It doesn't work like that. There are tons of key terms on your test, but it doesn't work like that. How it works is they will say there's a narrowing at the lower end of the esophagus on barium swallow. Bird's beak just helps you to remember what that is. You're not going to see those words but it helps you to understand and picture it in your mind and hold on to it. Whenever you can draw a picture in your mind, it's easier to remember long term. And our last one, esophageal varices, are often related to what other condition? It was portal hypertension, often caused by cirrhosis of the liver, often secondary to excessive alcohol use. All right, and that'll wrap us up for today. And we've started our journey through the gastrointestinal system, so super excited about that. Thank you for joining me here today. I am thrilled to have you on board. Again, if you would like more content, you can head over to physicianassistantexamreview.com/app, APP, and that'll bring you into the PAER app, which has been where I've been focusing most of my attention. And if you'd like to get all of the old podcasts, every single one, almost 200 episodes now, you can go to physicianassistantexamreview.com/podcast and see how to go ahead and get that. All right, take care. We will move to the stomach in episode 84. Good luck on your exams between now and then.